is chilling. I wish I was that unbothered with life. What's up, guys? Thank you for watching another video. My name is Nurse K. If you are new to this channel, welcome. I'm a registered nurse that works in the ER. This channel has everything to do with nursing, so if you are trying to be a nurse, this channel has everything to do with nursing, so if that is in any interest to you, subscribe down below, comment, let me know where you guys are in your journey, and let me know what I can do to help. Don't forget to also give this video a big thumbs up because it helps with the YouTube algorithms, and I am trying to get to 1K subscribers. And for those of you that are not new, it's been a minute since I dropped a video. It's been about a month. Yeah, it's kind of long, and life, what can you do? Sometimes life just kind of gets in the way a little bit. It was just life, you know? I'm gonna try to be a little bit more consistent. Also, I have a couple other things that I'm starting to think about also building. I want to start a podcast. That one is going to be very female orientated. It's going to be female based. I don't know if it's going to be about nursing. I think I kind of want to separate the ideas. So if you have any ideas about what you would like to hear in a podcast, you can let me know. Just let me know through the comments. Without further ado, let's get started. This video today is going to be signs and symptoms of heart attack and what to do when a patient comes in with chest pain. I work in the ER. So for those of you that don't know, I actually work in the ER, and this is something that we see a lot. And so I kind of wanted to give some tips and pointers on and kind of tell you guys what we do in the ER when somebody comes down with chest pain. So the first thing you want to do is assess the patient. It's so vital to do your across the room assessment on a patient, especially if you're triage. You want to make sure that you lay eyes on the patient and what does this patient look like? What are they presenting? Is their skin, within normal limits for their ethnicity? Are they diaphoretic? Are they red? Are they clenching their chest? Are they like stumbling? Are they not walking in a straight line? So you want to start thinking of all of these things before you even talk to this patient. Everybody presents differently. Just because somebody's walking in normally does not mean that you belittle their symptoms whatsoever. If a patient comes in, they're laughing, they're joking, they're on their phone, whatever, they are saying, oh yeah, I have chest pain. It started about 2 hours ago, and I just want to get checked out. Then you have somebody else come up, and they're, like I was explaining earlier, they're holding their chest, they're barely able to catch their breath. They're saying, I had 2 cardiac stents placed before, I ran 3 miles today, and that's normal for me, but today was just different. Okay, are you gonna treat them the same? Or are you gonna treat them different? You're gonna treat them the same. Policy is the best. Oh wait. What I mean to say is that you always follow a policy. And I think that as a new nurse, it's very vital and it's very important to make sure that you're following policy and procedure, because everything else is gonna come. You're not gonna be able to really assess the situation you're not gonna rely, I guess that's a wrong term. I guess you're not gonna rely on your initial assessment and your across the room assessment when you're a new nurse. But what you will fall back on is policies and procedures. So if you handle every single chest pain the exact same, you will never miss a heart attack. And policies are in place to make sure that doesn't happen. My advice to new nurses, especially in the ER, follow the policy through and through, even if you don't believe it, even if you don't agree, because it is gonna save you and it could save a patient in the long run. Keep that in mind. So you're gonna treat both of those patients the same. You're going to, within 5 minutes, you want to get an EKG, because the EKG is going to show you, it's going to show you if this patient really is having a STEMI. And a STEMI means ST elevation myocardial infarction, is what it stands for. And basically what that means is when you have your PQRS wave, right, it's showing you the electrical repolarization and depolarization of the heart, basically showing the electrical signals of the heart. And whenever there's some sort of ischemia, the blood vessel in the heart is completely blocked or kind of blocked, it's gonna show on the EKG, right? STEMI, ST elevation. The different areas on the EKG is going to show you exactly where the ischemia is. If you don't use it, you lose it, and I was taught that in orientation. But to be honest with you, the doctors really are a lot better at kind of reading the EKG. I can read it and I can tell you this patient's having a STEMI, I can tell you they're in AFib, I can tell you that they're in VTAC, VFib, like things like that. But as far as where exactly the infarction is, it takes a little bit more time. And anyways, there's just too much else. Anyways, you want to get the EKG, you want to get a large bore IV, preferably 2, which is like an 18 gauge, especially if the patient is presenting like really horrible, like really bad. We usually give aspirin 325 because it acts as a blood thinner. We give heparin, which also is is a blood thinner. It's going to thin out that blood. And then we give morphine, which is going to dilate those blood vessels. So basically what we're trying to do is we're trying to save time, right? We're trying to buy time and for this patient to possibly go to cath lab. So what we're doing is we're giving them blood thinners, heparin, we're giving aspirin to thin out that clot. Then we're giving morphine and nitro, sublingual usually, put it right under the tongue, to dilate those blood vessels in hopes that blood can kind of start going past the clot as the blood thinners are trying to break it up, you know what I mean? And then supplemental oxygen if needed, but it doesn't hurt. Even if they don't need it, they're starting at 96% or something, it doesn't hurt to give them oxygen, right? Whenever you're in school, I know that there is a acronym that I even learned is MONA, which is morphine, oxygen, nitro, and aspirin. We don't give it in any particular order. Usually it's all happening at the same time. We also can give Zofran for nausea because sometimes they're nauseous or morphine will make them nauseous. That's usually what we do. We send labs down. Now that's if they have an ST elevation. So let's say a patient comes in and we do the EKG and the EKG is normal. Then we do blood work and their troponin levels. Troponin, dun, dun, dun. Yeah, it always makes me think of that song. But troponin is an enzyme that the heart releases when there's some sort of ischemia going on, or basically something bad is going on. Your troponin level is going to be elevated. Usually whenever somebody comes in with chest pain after 2 hours, we usually do a repeat of the troponin because we use the first one as a baseline and then we use the second one to see if the troponin goes up or if it goes down or if it stays the same. And if it goes up, that's obviously not a good sign, and that's usually whenever they get diagnosed with a non-STEMI, which is non-ST elevation myocardial infarction, which means it's kind of like not as severe, like it's like a baby heart attack or like a mild heart attack or something that could lead into a real STEMI. So it's still something you need to be taken serious. This patient may get admitted and for observation, or they may get admitted for a stress test, and then depending on that, will change the course of action after they get admitted and go upstairs. But if they are having a STEMI, they generally go to the cath lab. Not generally, they go to cath lab. It's usually fairly quickly. Nurses just basically swarm patients whenever there is the STEMI activation. Let's bring it all back. You want to pay attention to your initial assessment, your cross-room assessment. How does this patient look? You want to get the EKG within 5 minutes. You want to get an IV started, get blood work, send that. If it's a STEMI, you'll know from the EKG. And by that time, that's when you do MONA, right? You're going to do MONA, throw in some Zofran with that, 2 large bore IVs. And yeah, that's it. And then patient will go to cath lab. Usually cath lab, they insert a catheter, either the femoral artery. I feel like the femoral artery is a little bit more popular. The femoral artery, oh my gosh. The femoral artery in your leg, or they'll go through your wrist as well. It seems like they're going through the wrist more frequently though, I will say. But yeah, anyway, so they bring the catheter all the way up and into your heart, and they'll place a stent if needed wherever the STEMI or wherever the blockage is. That's what we do for STEMIs in the ER. Chest pain doesn't always have to be cardiac. It can also mean, you can have a PE, it could be undiagnosed CHF. People present differently, and it doesn't necessarily always mean that it has to do with the heart, but it's important to treat everything the same because it's gonna, one, you're following policy, it's gonna save you as a nurse with your license, and it could also save a patient. But number two, what was number 2? You're developing good habits that way, because then even if you go autopilot, you're still going off of policy. Just policy in general is the best policy, okay? And also another thing that I kind of want to throw in here that may not pertain necessarily to chest pain, but just in general, if you have a patient that, especially in the ER or even on the floor, if you have a patient that is presenting a little differently than what they were earlier, than what they were when they initially came in, and like we kind of call it circling the drain, because it's not like the movies where patients just like, I mean, if they have an epidural brain bleed, yeah, but generally if a patient is about to code, they don't just code. They give you a lot of signs, and if you are not careful and you don't pay attention to those signs, then it's an oh crap moment. But if you are assessing your patient, you're listening to your patient, and you're advocating for your patient, there's no way you're going to miss those signs. And it's important to make sure that whoever's in charge, generally charge nurse, knows what's going on. So there's been times where I've had patients that are like we call it circling the drain, and I'm like, hey, like this patient doesn't look as good as they did when they first got here. Their breathing's different, or she's starting to, like, you know, or I'm hearing wheezing now. I feel like her throat's closing up. I don't have a good feeling about this. Listen to your intuition. And for new nurses, it's a lot harder because you don't really have that experience to kind of go back on. And I've only been a nurse for a year, so there's plenty of things that I don't understand. But what I do know is that I listen to my patient, and I listen to the vital signs that I see. If that blood pressure is going up or down, if that heart rate is getting funky, that oxygen level is like, for the most part, I try to make sure that charge is aware, just like throw it in their ear a little bit. Like, hey, person might code, just letting you know, in case when they do, you know it happened. but they appreciate it, because then when the patient really does go, it's not like, what's happening in here? And if you're wrong, if your intuition's not right, hey, you're learning, you're gonna continue to grow, and you know, you took it serious. Sometimes doctors, they have so many patients that they don't really, it's not that they don't care, it's not that they don't see it. You have way more patients than I do, and so there are times where I feel like we are the telephone line through for our patients and advocating for them and telling the doctor. Or sometimes patients feel more comfortable telling you things that they won't tell the doctor. So that's all I really have. And also another thing I am going to start doing at the end of every single one of my videos, I'm going to start leaving you with some sort of positivity, because I feel like this world is just going, you know, spiraling down, just like what I said, circling the drain. I feel like this world is like circling the drain. I think that this is a time frame where we need to start to come together and respect one another. You don't know what's going on in other people's lives, and I think that you can have I just feel that we should just be a little bit more positive with each other, be a little bit more gracious and understanding. I just want to do my part in kind of giving a little bit more positivity into this world. So I'm gonna leave you with a quote, and I've said it on my last couple of videos, so next video I'll have a new one, but this is my favorite quote of all times. Absolutely adore it. It's from Bob Marley, and he said, "Emancipate yourself from mental slavery. Only you can change your mind." And it is so true. For discrimination, racism, capabilities, mentality, everything, you are in control of your own life. You're in control of where your mind goes. If you want to be positive or if you want to be negative, you are in control of that. Always. You feel like your life is a disaster, you know, nursing school's hard, COVID is beating you down, losing jobs, and everything else that this world is like, all this other stuff that's going on in this world. Understand that it's like you're on a train. And if an event happens to you, you have a route to go positive or you have a route to go negative, and the decision is yours. Wherever you are at in life, you are at the greatest maximum benefit for you. Even though you're going through it now, there is something that is happening to you, whether it's something's making you stronger, it's making you more aware, making you think harder, work harder, whatever. It's shaping you for something that's gonna happen to you in the future. I'm really big on energy, positive energy, and whatever you give out to this world, I do truly feel like will come back to you. And the energy that we give out to ourselves too. I mean, you know, we can be pretty mean to ourselves as well. And I'm here to tell you, love yourself, love who you are. Don't be ashamed of who you are. The scars, battles, everything that you've gone through has made you you. And show the world that. We're not perfect. Nobody's meant to be perfect. We all have flaws and we all have things that we don't like about ourselves. But that shouldn't overshine the positive things that we can give to the world and that we can give to ourselves. So I challenge you to do something positive today. Whether it's positive to you, just doing something nice for somebody you love or care about, or even a stranger that you've never met. That's all I have. Please give this video a big thumbs up. I hope you learned something, and until next time, peace.